So let's just continue our case. So this patient, remember, he had the ARPI switch, had the SPOT mutation, no germline mutations. And after 1 year of PSA response to enzalutamide, his PSA started to rise. So often in the ARPI switch, the treatment duration is short, like the median is about 4 to 5 months. This guy got a year, probably because, of the SPOT mutation. But he's progressing now, and he had another PSMA PET CT, and now he has more bone lesions. In fact, now he has 8 new bone metastases. They're small and they're asymptomatic. He has some fatigue, but otherwise is feeling well. His hematocrit is consistent with being on androgen deprivation therapy, a little bit low, but not needing treatment. And he notes that what's important to him is remaining active and limiting his medical visits. Those are his goals of care. So given this about this patient, what is the next best treatment option for management of his disease? So now he has MCRPC, post-ABI, and post-ENZA. So the most commonly chose option is PSMA radioligand therapy. A little bit of smattering from the other ones. Again, I don't think there's a wrong answer here. So this patient, the enzalutamide was stopped, and he was treated with PSMA radioligand therapy. And the reason why I chose that one and chose that as the right answer, but again, there's no really wrong answer, is that his goal of care was to limit his hospital or clinic visits. And one thing I like about PSMA radioligand therapy is the 6-week interval compared to the 3-week interval for chemotherapy. And I personally find that makes a big difference for patients' lifestyles to, essentially cut in half the amount of clinic time you have compared to chemotherapy. And I'd also like to just mention he was started on denosumab for his progressive osteopenia, and I think paying attention to and taking care of the bones in patients receiving radioligand therapy is very important and should be high on the list of, the details that you're taking care of. He tolerated the first 3 cycles with minor increase in fatigue and minor progression of his anemia. Hematocrit remained 27, so he was not on any anemia supportive therapy. He had a PSMA spec, which we can ask Jeremy to comment about in the discussion after 3 cycles, which showed a decrease but persistent PSMA uptake in most lesions, so responding, and no new lesions. And his PSA dropped from 5 to 2.5, and he had no GI or renal toxicity. So he's doing well on his PSMA RLT. So the next question is, what treatment is now recommended? I would say the correct answer is that second one there that most people chose. Go to 6, which was the number of cycles considered standard of care in the VISION trial. The reason why, we'll go through some of this in the subsequent slides, but the first answer I think is not the best choice, is that he still has PSMA measurable disease on his PET. We do consider adaptive therapy, but usually in the situation where the PET doesn't show any disease now, your target is gone. And that's not become standard of care, but has been the subject of some phase 2 trials. The reason why I wouldn't stop the RLT and start docetaxel, while docetaxel is FDA approved in this setting, is the patient's tolerating it and responding. And there's no reason to reduce the dose. So those are things we can talk about further in the discussion. Okay, so I'm going to just go over a few of these important trials: the VISION trial, the therapy trial, the PSMA-4 trial, and what's called the PSMA addition trial. So these are our approved therapies in metastatic CRPC that we've been talking about. And as shown here, the median overall survival is based on the both the treatment group in these trials and the control. And you can see the difference in the overall survival. So all of these choices, from docetaxel to um, second ARPI, radium, they all have survival advantages around 3 to 4 months. So we have a lot of work to do, I would just say, in the field to, get better options for our patients. And the amount of therapies in development now is just amazing and very promising, including a lot of new radioligand therapy. But I just put this up as a top of mind start the discussion of where we're at. So the Vision trial, I think most of us are probably very familiar with this. It was presented at ASCO during the pandemic in 21. I was the discussion for the plenary discussion, and it's a really important trial in advanced prostate cancer and randomized PSMA lutetium 617 to standard of care options. And this is the overall survival. There was a statistically significant form and hazard ratio of 0.6, so a 40% improvement in overall survival, which translated to 4 months and made this treatment an option in metastatic castration-resistant prostate cancer. These patients were post-chemotherapy in the Vision trial. Here's the rPFS, which was about 5 months better. PSA response, 50%. Overall response by RECIST looked good, and the overall survival. So, got this treatment FDA approved and should definitely be considered an option for patients who have metastatic castration resistant prostate cancer. Some data that are worth discussion. We have limited data on sequencing, especially things that need to take into consideration patients' baseline comorbidities and their goals. Just want to put a word in that clinical trials should always be considered when available, and that these trials don't really address some of the conversation we've had earlier on SBRT to oligometastasis, but that should also be in your back pocket as a treatment option for patients with low volume oligoprogression. The next trial that I just wanted to mention is this therapy trial, which was a smaller trial. It's a 200 patients were randomized to PSMA 617 or chemotherapy. So this is trying to look at sequencing, which is why even though it's a smaller trial, I put this in for us to discuss. The data from this is shown here. And as you can see, the hazard ratio in favor of PSMA lutetium was 0.6 and statistically significant in terms of progression-free survival. No difference, however, in overall survival. So I think what this tells me, in the short term, there may be some benefit for choosing the radioligand therapy over a second chemotherapy, but in the end, there was no survival difference. So, but this is the data that we have looking for that. So let's just move a little bit to earlier stage, and this is the PSMA-4 trial, which did change our practice patterns. So this is PSMA lutetium 617 compared to ARPI switch in MCRPC, pre-chemotherapy with a very healthy improvement in rPFS. And the hazard ratio there was 0.5, so 50% improvement, which is big, and no detriment, I would say, in overall survival. Now there's crossover and other treatments that these get, and survival follow-up that needs to, longer follow-up. So I would say this doesn't um, impact how I think about giving this treatment before chemotherapy, and has become, I would say, the standard of care to consider PSMA lutetium before chemotherapy in MCRPC. And this is the PSMA addition trial. So this is for patients with hormone sensitive prostate cancer, and patients were randomized to PSMA 617 versus standard of care, which in general were ARPIs. And then when they reached radiographic progression, they were allowed to cross over. And this data, this is the schema here. And get to the end. This is RPFS by blinded independent review, which is also looks positive. And this trial has not been these data have not been enacted yet by the FDA, as they're waiting for more data. And so we're not using PSMA RLT for here's the overall survival for metastatic hormone sensitive prostate cancer at this time. But as these data mature and the FDA makes their ruling, it's possible that this will come forward. You can see here the hazard ratio is 0.884 for survival, not statistically significant, but not worse, not over 1. So here's the AEs. I think the AEs of RLTs are very well known at this time, probably definitely worth some discussion in the discussion, but cytopenias, anemias, dry mouth, and some low-grade GI toxicity are the general what we see. Here's PSMA addition in terms of the FACT-P, and I'll just summarize because I think we need to move to the discussion. But PSMA lutetium 617 is a standard of care for MCRPC, both pre and post chemotherapy. The results of the PSMA addition are favorable and support the use in metastatic or as an option in metastatic hormone sensitive prostate cancer, but are not currently FDA approved. There's many options for MCRPC therapeutics. And data on sequencing is limited. Important to get to understand the nuances of the trial. I think the ASCO living guidelines are informative and will be helpful to practicing prostate cancer doctors. And not discussed today, but I just bring forward for attention, is that there are many RLT combination therapies that are under investigation. Adaptive approaches that I mentioned are also under investigation. New RLT radioisotopes and targets are under investigation. And then the language that we've mentioned before, prostate cancer working group, at least for clinical trials, is going to evolve into APMN and APMR, naive and resistant for prior ARPI.